The following podcast is part of a certified educational activity titled Optimizing Patient Outcomes in RCC Through Safe and Efficacious Use of Immuno-Oncology and Targeted Approaches, Teaming Up to Mitigate and Manage Adverse Events and Maximize Survival, featuring Dr. Brian Rini from Vanderbilt University Medical Center in Nashville, Tennessee. Access the entire activity and complete the post-test at peerview.com/BZT860. Downloadable slides and practice aids are also available.
Hello, I'm Brian Rini from the Vanderbilt Ingram Cancer Center in Nashville, Tennessee. Welcome to this educational activity entitled Optimizing Patient Outcomes Through Safe and Efficacious Use of Immuno-Oncology and Targeted Approaches, Teaming Up to Mitigate and Manage Adverse Events and Maximize Survival. We'll cover expanding therapeutic developments in the frontline management of kidney cancer. Our goal today is to explore some of the recent advances in the treatment of kidney cancer, focusing on combination therapies, and describe what these advances have meant for patients with advanced kidney cancer and how providers can best use them for the maximum benefit of patients. As many of you know, kidney cancer has undergone a transformation in the last 20 years. If you look to the left of this timeline, you'll see high-dose interleukin-2 as the only drug approved in kidney cancer for a very long time, and what I often refer to patients as old immunotherapy. About 15 years ago, we then entered the era of targeted therapy, or tyrosine kinase inhibitors, TKIs, as listed on this slide. And these were single agents that were targeted against the Vegf receptor. So they were anti-angiogenic agents and generally pretty good at controlling disease, shrinking tumors, but were not curative, but certainly provided a major advance in this disease. And then more recently, we've entered the immunotherapy and immuno-oncology combo era, where at first single agent nivolumab and then rapidly combinations have developed based on immunotherapeutics, checkpoint inhibitors that we'll talk about, and now combining our two most effective therapies for a new standard in this disease. But certainly an exciting time with several FDA approvals and providing, I think, great hope to patients when they come in to have this disease treated. One of the things we think about in kidney cancer and any solid tumor is prognosis. Patients always want to know, what's going to happen, doc? Do I have a fast-growing disease? Do I have a good prognosis or poor prognosis? In kidney cancer, we've by and large moved to the IMDC criteria. That's International Metastatic Database Consortium that Danny Hang put together many years ago and continues to be used today. This was a database of several hundred patients treated with Vegf-targeted therapy, and then several factors were found to influence survival of those patients that you see listed on the left-hand side. Performance status, time from diagnosis to treatment, and then several lab values. And based on the number of adverse risk factors, patients were divided into favorable, intermediate, or poor risk, and the outcomes with different survival outcomes. And so the way I think of these is that if a patient's favorable risk, they either have inherently slow-growing disease, as some kidney cancer patients do, and or they're very Vegf responsive. Again, remembering all these patients from this original data were treated with Vegf targeted therapy. So either a patient had indolent disease or they were just so responsive to treatment that they did well. And so it's important to remember this as we talk about data and how we might apply these criteria. I do think they're useful in clinical practice. They give the doctor and the patient some idea of prognosis. And again, we're starting to integrate them into our therapeutics. So what are the standards of care? Just to give you the big picture, this is NCCN guidelines, and these are rapidly changing as new data are coming out and new drugs are getting approved. And you see they're broken down into favorable and poor intermediate, and those are the IMDC risk categories that I just spoke of. We see, again, combination therapy as preferred, axitinib, pembrolizumab, cabozantinib, nivolumab, and ipilimumab, nivolumab as the preferred combination therapies. And then some single agents. And we'll go into the details here, certainly, as I think NCCN categories and recommendations tend to just sort of be lists of drugs, but obviously can't get into the granular details as we'll do today. Kidney cancer is a very interesting biologic disease, and it's driven primarily, although not exclusively, through angiogenic and inflammatory pathways. There's a recent publication that I was involved in Cancer Cell, which broke down kidney cancer patients' tumors into 7 clusters based on RNA gene expression. And what was shown is that cluster 1 and 2 are predominantly angiogenic. They're driven by angiogenic pathways. They have specific RNA profiles and also characteristic DNA alterations. Clusters 4 and 5 were more inflammatory pathways. And then clusters 3 and 6 were probably something different altogether. And I think this is the biggest data set that's ever been put together in terms of the biology of kidney cancer, but it really reinforces the drugs that we know have activity, i.e. Vegf TKIs and checkpoint inhibitors. We're not yet using these clusters to assign therapy, although those efforts are ongoing, but I think it just reinforces the biology of kidney cancer as predominantly driven by these pathways and really sets the stage for what we'll talk about for combination therapies. This is a summary slide of the major combination trials in kidney cancer that have shown us overall survival advantage. There have been some other combinations tested I won't talk about because they've not produced survival advantages, but there's an all-immune combination of ipilimumab, nivolumab, shown in Checkmate 214 to prolong survival, and then 3 combinations which combine one checkpoint inhibitor, a PD-1 inhibitor, plus a small molecule Vegf TKI, and we usually call those IO-TKI combinations. All 4 have shown pretty significant survival benefits compared to the old standard of care of single-agent sunitinib. They have long progression-free survivals that are actually longer with the IO-TKI combinations, which reflects inclusion of that anti-VEGF agent, which, as I mentioned at the outset, is very good at shrinking and controlling tumors. High response rates into the 60 and 70%, which is really unprecedented in kidney cancer. Complete response rates of 10 to 15%, and really important, again, survival benefits across combinations. I'm going to present some data from these trials. We're going to try not to compare across trials, but really just to set the stage that they all have activity and they all have pluses and minuses that we can note as we go through. So dual immune checkpoint blockade and immune targeted combinations are recent additions to these practice guidelines. And so let's talk a little bit about the rationale for dual immunotherapy and look at the recent evidence for this approach. So a long time ago now, when these drugs were first tested in melanoma, it was pretty clear that there are different checkpoints that are important in the anti-tumor T cell response. So the basics of tumor immunology is that an antigen-presenting cell, a dendritic cell or a tumor cell itself, presents antigen, presents protein to a T cell receptor, which stimulates that T cell. That's the fundamental interaction that leads to anti-tumor T cells. Like most things in life, however, this physiology is regulated by what are called checkpoints. So it's sort of the brakes on the immune system. So there's constant presentation of antigens in your body. And if we didn't have these brakes, then that's where autoimmune disease comes in, where there's an over-vigorous response to, in that case, normal antigens, normal proteins. In the case of tumors, we want a vigorous T cell response, but these checkpoints are preventing that T cell response. And so it was recognized fairly early on that if you block one or more of these checkpoints, you can release the brakes of the immune system and allow an anti-tumor T cell response to occur. The major checkpoints that have been clinically developed are programmed death 1 or PD-1 and CTLA-4. CTLA-4 actually came first, and it was ipilimumab was approved in melanoma now many years ago, and then the PD-1 inhibitors came along. And so there's synergy in combining these. They're different approaches. They act a little differently. And so this dual immunotherapy approach, again, first studied clinically in melanoma, has now been studied in kidney cancer. The major trial that has studied this, the phase 3 trial, was called Checkmate 214. And as you see, it was a very large, over 1,100 patient trial, almost 1,100 patients with treatment-naive clear cell kidney cancer, standard other phase 3 criteria. They were stratified by those IMDC risk factors that we talked about in region, and then randomized equally to what we call an ipi-nivo regimen, which is 4 induction doses. So dual therapy every 3 weeks times up to 4 doses, and then maintenance nivolumab given in the trial as every 2 weeks. And all the trials I'll talk about have a common control arm of sunitinib 50 milligrams, 4 weeks on, 2 weeks off. That was the standard of care in kidney cancer for probably over a decade. These data have been presented and published many times. The updated data was presented by Laurent Saubiger in a recent ESMO open publication from 2020. And what's shown here is the progression-free survival. And the way the Checkmate data is often broken down is in an ITT population, so all comers, intent to treat, in the intermediate and poor risk population, and that was actually the primary population of the study. The primary endpoint was based on that population, and then the favorable risk population. So obviously favorable plus intermediate and poor equals the ITT, but these data are often broken down this way. What you see is very interesting in terms of PFS. So if you look at the ITT and the intermediate and poorest populations, you see very similar shaped curves, which I would call classic immunotherapy PFS curves. They're overlapping for a while, often through the median, and then you start to see a tail of the curve for progression-free survival in the immunotherapy-containing arm. And these data have now over 4 years of follow-up. You see this was the 48-month PFS, which means that 48 months was the minimum follow-up for patients on this study, so a 4-year follow-up. And you see the tail of the Ipi-Nivo curve for PFS settling in about 30+%. So if you think about that, that's a third of patients who started on this regimen at least 4 years ago who are still progression-free. Some of them on drug, some of them off drug, but pretty impressive durable disease control. And I think that's been pointed to in these data and is certainly a strength of these data. If you look at the favorable risk population, there's a different story. So the sunitinib curve is on top here. So again, better disease control, at least initially, in a favorable risk population, which tends to be more angiogenesis driven. And again, Vegf TKIs are very good at controlling disease. There's no apparent tail of the curve here. You don't see that same shape. And the sunitinib curve likely is to not have a tail. The Ipi-Nivo curve has a different shape and may actually have a tail about that same, say, 20 to 30%. So this is a nuance of these data. Many people use this as a reason not to give Ipi-Nivo in favorable risk patients, and I'll show you the data for IO TKIs in a minute. But there's clearly a subpopulation of favorable risk patients who can benefit from this therapy. So suffice it to say, it's an area of ongoing investigation and debate, really, among kidney cancer experts, but certainly a robust regimen and some benefits in terms of long-term disease control. Same populations now looking at the 48-month minimum overall survival. And again, intent to treat and intermediate and poor, you see very significant advantages for the Ipi-Nivo over sunitinib, hazard ratios in the mid 0.6 range. You see the median overall survival in the ITT population has not been reached, and it's 4 years in the intermediate and poor risk population. So remember, in the days of interleukin-2, the overall survival for kidney cancer was 12 months. When sunitinib and its cousins came along, it was about 2 years, 2.5 years. And now we know it's going to be at least 4 years, and that's not even including the favorable risk patients. So I usually quote patients a median survival of about 5 years in this disease, all comers walking in the door. Not nearly as long as we want it to be, but a major, major advance over where we were a couple decades ago. Again, in the favorable risk population, the sunitinib curve is generally on top until you get to the end, and really the jury's still out. It's still a relatively low number of events. There probably won't be any survival difference either way. And it just means favorable risk patients quite obviously have a more indolent biology. They do well regardless, and they often get subsequent therapy. So unfortunately, they have a shot at many different types of therapy and often can respond to multiple lines of therapy. This is just the response rate data, again, broken down into the same categories. Response rates in the 40% roughly for Ipi-Nivo, less so in favorable risk. You see complete response rates in about the 10% range. So again, remember, when we looked at those PFS curves, we saw disease control in the 30% range. So what that tells you is it's a lot more than just the complete responders who are doing well long-term with this therapy. And that's a really important point. When these data and other data came out, we said, oh, it's all about CR rate. The CR rates are the only patients who do well. That's absolutely not the case. There's another 20% of patients who do well long-term, even if they happen to not have normal scans, right? So they have what we might call a deep PR. And then the bottom row here shows ongoing responses. So 2/3 of patients who respond to Ipi-Nivo will maintain that response now out at 4 years. And it's actually a higher percentage if you look just at the complete responders. So depth of response probably does matter, but durability of response is impressive and important with this regimen. So let's further explore treatment options that are immunotherapy based, in this case, in combination with tyrosine kinase inhibitors. We'll look a bit at the rationale and then look at the data. There have been numerous trials assessing the efficacy of various checkpoint inhibitors in combination with Vegf pathway inhibitors, and 3 of these combinations are now FDA approved. So the rationale for combining these, I would say, is twofold. The very simple rationale is that immunotherapy by itself has activity, Vegf blockade has activity, and as we do very often in cancer drug development, we combine things with non-overlapping mechanisms and hope that they work better than either drug alone. That's a very simple clinical rationale and done plenty in the world of cancer drug development. The more nuanced explanation for why these two mechanisms may work well together is shown on this slide. It's been long recognized that VEGF is immunosuppressive, that the presence of VEGF has adverse effects on the ability of a patient to mount an effective anti-tumor T-cell response. There's promotion of immunosuppressive cells like myeloid-derived suppressor cells and regulatory T cells. There's effects on dendritic cell maturation. There's effects on blood flow to organs in terms of getting these T cells where they need to be. Many decades, I'd say a couple decades of data to support that VEGF is immunosuppressive. And therefore, the thought is that if you can suppress the VEGF, then you would allow a more effective anti-tumor T cell response. And that's now been borne out, certainly in kidney cancer, with the data that I'm about to show you. This is the Keynote 426 study, which is the first IO-TKI study that was reported. And it's the combination of pembrolizumab, a PD-1 inhibitor, plus axitinib, which is a potent small molecule, very selective VEGF receptor inhibitor. Similar to the other trials, this was a large trial in frontline kidney cancer, newly diagnosed clear cell kidney cancer with other standard eligibility, and stratified again by IMDC risk group and region. And patients were equally randomized to either the combination of pembrolizumab every 3 weeks up to 35 cycles, which is about 2 years of therapy, and axitinib, which is the standard starting dose of 5 milligrams twice daily, compared to a standard sunitinib control arm. Primary endpoints were both overall and progression-free survival. And as you see in the bottom of the slide, the first interim analysis in the publication New England Journal reported very robust results, hazard ratio of 0.53 for survival, PFS hazard ratio of 0.69, and a response rate advantage of approximately 59 versus 36%. So the very early efficacious signals from this regimen, and we now have further follow-up. These are now the updated data that were presented at ASCO 2020 and published in Lancet Oncology last year. And again, you see very impressive survival curves that split early. At 2 or 3 months, there starts to be a split in survival. And they really stay split in parallel throughout, with over, about a 10% difference in survival at the 1 and 2 year landmarks that you see listed there. And again, median survival not reached yet with the pembro-axi combination, but I'll again estimate that it's going to be certainly in that 4 to 5 year range, as I discussed with the ipi-nivo combination. And these data now have more mature follow-up, median follow-up of about 2.5 years. Again, not quite the 4+ years from Checkmate 214, but a reasonable amount of follow-up now. This is the updated PFS in the ITT population. Again, curves split early, they stay split throughout. You see about a 4-month difference in median, significant hazard ratio, and again, about a 10 or 15% difference at each of those landmarks. Looking at the response in this population, response rate of 60%, again, at the time, the highest response rate that had ever been reported, complete response rate in that 9% range, and a median duration of response of about 2 years. And admittedly, all the IO-TKI data just needs more follow-up. We need to know how durable are these responses, how many are sustained, where's that tail of the curve in terms of long-term progression-free survival, and we just don't know it yet. These data sets are just now getting to the point where we can start to think about it, but probably need another year or two to really make firm conclusions. I will also note that the primary progression rate on IO-TKI regimens is about 5 or 10%. And what I mean by primary progression is a patient starts on treatment and their first scan shows progressive disease. So they have no benefit from treatment, their disease progresses right through it, obviously the worst scenario. And it's about 5 or 10% across these data sets, which is important. And people have pointed to that to support the use of IO-TKI regimens in patients who need early disease control. Bulkier disease, more symptomatic disease, you definitely get better early disease control with an IO-TKI regimen. Again, only 5 or 10% of patients not benefiting at all, compared to ipi-nivo, where that's about 15 to 20%. So a clinical difference that might be used to pick a regimen. When we look at, I mentioned sort of depth of response before when I was talking about CR rates and how they were important, but not the whole story. We looked in Keynote 426 at depth of response. So if we look at the 6-month landmark, so take everybody who's been on therapy 6 months and look at how much their tumor bulk has shrunk, and broke it down into arbitrary divisions of 0 to 30%, 30 to 60, and so on, and said, gee, does the amount your tumor shrinks, does the percentage your tumor shrinks impact your survival? And what we saw, and this has been shown in some other data sets and other trials, is that patients whose tumor shrank by at least 80% had very similar survival to patients who achieved a RECIST-defined CR. And again, I think this just reinforces that it's not so much about making the scans normal, it's about shrinking tumors to some small amount and then keeping them shrunk, and that will translate into better survival for patients. This is all exploratory, it's very small subsets, but it's a pretty consistent theme across trials. There are efforts ongoing to combine the large data sets and look at this in much greater number of patients. But I think it's important for the field to understand this and perhaps use these data not only in the clinical care of patients, but as we're developing new drugs and combos, this might be an endpoint. Instead of just looking at response rate or having to do large trials for every combo, we may be able to look at this as an early signal of activity, i.e. what percent of patients achieve that 80% shrinkage, and use that then to pick regimens for further development. But all that's very experimental right now. There was an important update at ASCO GU 2021 that Betsy Plimak presented, which was looking at the outcomes of patients who made it to 2 years of pembrolizumab. So remember in that schema, I told you that pembrolizumab was given up to 35 doses. That turns out to be almost exactly 2 years of treatment. And this is a decision that was made across the pembrolizumab program. So across all the pembro trials and all solid tumors, to my knowledge, it stopped at 2 years. If you look at the melanoma data, again, different disease, but that has the longest follow-up, most patients who are doing well when they stop pembrolizumab at 2 years continue to do well in that disease. And again, it provides reassurance that once you generate an anti-tumor immune response, you don't necessarily need to keep giving drug. And we can argue whether 2 years is the right amount or should have been 1 year, et cetera, but nonetheless, that's what the time point was chosen. And the data presented at ASCO GU looks at this from the Keynote 426 study. So if you look at the overall survival, obviously everybody who makes it to 2 years is alive, so that curve is flat up until 2 years. And then 95% of people are alive 1 year later, which is really all the follow-up we have. So there's not much follow-up beyond 2 years, but this is the first signal. So it tells you quite obviously that the vast, vast majority of patients who are alive at 2 years and doing well on pembro are going to remain alive a year later. That would be expected. If you look at the progression-free survival, it's a little more complicated. So I should have said, first of all, about 25 or 30% of patients make it out to 2 years of pembrolizumab. So that's a fair number of patients who make it there. Some of those patients would have progressed before the 2 year mark, and the trial would have allowed them to stay on. So it's not that they're all progression-free at 2 years. A proportion of patients, about 10 or 15%, had already progressed, but because of the way the study was written, they were allowed to stay on post-progression. And then if you look a year out, probably another 10% of patients have progressed at the 3 year mark. So again, early data, so hard to make definitive conclusions, but it appears that the vast majority of patients continue to remain progression-free and alive even after stopping pembrolizumab. We absolutely need more data and more follow-up from this trial to know what really happens, because it's a big topic in kidney cancer about, gee, do I really need to continue both drugs forever? Can I stop the TKI? Can I stop immunotherapy? The more you continue drugs, the more side effects you'll have. So it's clinically relevant to patients, and we're just now getting to the point where we have some reassuring data, but I would say the jury's still out on outcomes following stoppage of treatment. Another study to mention briefly is Javelin Renal 101. This was not in the initial table I showed you because it has not shown a survival advantage, but it was very similar to Keynote 426 in that it was axitinib as the Vegf partner, in this case plus avelumab, which is a PD-L1 inhibitor, compared to sunitinib. Otherwise, standard criteria and stratification, as you see, are pretty similar across these studies. What this study showed was a progression-free survival advantage in a PD-L1 positive population. So for various reasons, based on initial data with this combination, it was felt that expression of PD-L1 on tumor cells would enrich for response, and that's why that was chosen as the primary population. The long story short is it turns out in kidney cancer, PD-L1 expression is not a great biomarker. We don't use it clinically. It may enrich a bit for response in some settings, but it's generally not distinguishing, and so we don't use it in clinical practice. But nonetheless, that was the primary endpoint for this trial based on other preliminary data. And you see a progression-free survival advantage that's pretty similar to the Axi-Pembro combination. Hazard ratio is 0.62, median slightly lower, but same relative advantage. But again, no overall survival benefit was shown. It hasn't been a final analysis yet, but I think it's unlikely that this regimen shows a survival advantage. It is FDA approved, although not much used because we have other regimens with proven survival advantages. Checkmate 9ER is one of the more recently reported studies. So this is an IO-TKI combination. It's nivolumab as the PD-1 backbone and cabozantinib as the VEGF agent. Cabo is an agent that's very active not only against the VEGF receptor, but against other receptors, such as MET and AXL. And it's postulated that some of that additional inhibitory activity accounts for some of its clinical activity, probably also accounts for some of the toxicity of this agent, which tends to be a little more toxic than the strictly VEGF-targeted agents, but nonetheless very active. And this combination, again, tested in a large phase 3 trial, very similar to the other trials, stratified by IMDC and region, and in this case, tumor PD-L1 expression, although I told you that we now know that that doesn't matter. And looked at this combination compared to, again, a standard sunitinib control arm. These were the updated trial results. Again, this data was just published in New England Journal, but the updated results were published at ASCO GU 2021. And you see, again, an impressive progression-free survival advantage. So nivo-cabo with a 17-month PFS and a hazard ratio of 0.52. Again, landmark differences that you see there. So very, very durable and impressive disease control, which is a theme of these IO-TKI regimens. This is the overall survival curve, and this shows an advantage to the nivo-combo combination against single-agent sunitinib. Again, you see these curves split early and stay split. Median not yet reached for nivo-cabo, about 30 months for sunitinib, and you see about a 10% advantage in survival at the 12 and 18-month landmark. And as noted, a hazard ratio in the mid-0.6s, which was significant. So again, a very consistent signal across IO-TKI trials with a survival signal compared to sunitinib. Looking at response rate, again, similar to the other IO-TKI regimens, overall response about 55%, complete response not quite 10%, duration a little less than 2 years, and over half the patients with an ongoing response. So again, remember the IO-TKI combinations are still fairly immature in terms of data, and that durability of response, that tail of the curve, we don't really know with these regimens yet, and I think will be important. Clearly, the IO-TKI regimens provide superior upfront disease control, higher response rates, longer progression-free survival, more tumor shrinkage, less patients who progress through. Will they provide the durability of a dual immune regimen? That is the question in kidney cancer now, and we're probably a year or so away from knowing the answer to that. The final IO-TKI study was the CLEAR study, which was just presented and published, and is in some ways the most impressive data. So this was a combination of lenvatinib, also a multi-targeted TKI plus pembrolizumab, compared to sunitinib, and that's the primary comparison, comparison of interest for our purposes today. There was also a lenvatinib plus everolimus arm. This combination, which is a VEGF plus an mTOR inhibitor, is approved in kidney cancer in a refractory setting based on a phase 2 study. And this inclusion of this arm was basically a post-marketing requirement for the company since it was just a randomized phase 2 that led to approval. And so some interesting results, but I think primarily we'll focus on the IO-TKI combination. And again, you see the eligibility and stratification very similar to the other studies. If you look at progression-free survival for this regimen, you see very impressive curves here. If you look sort of at the top and the bottom curve, the IO-TKI, the len-pembro as we call it, versus sunitinib, a median progression-free survival of almost 2 years. So the absolute number is the highest we've ever seen, and the lowest hazard ratio is 0.39. And sunitinib coming in at 9 months, which is pretty typical for sunitinib. 9, 10, 11 months is pretty typical for PFS. So it's unclear right now, and there's some debate in the field whether this is just a vagary of the trial and it happens to look a little better because there's variability across trials, or if there's something truly special about this regimen with the longest progression-free survival and the highest response rates, et cetera. I don't think we really know, but I think we can certainly say that just looking at these data by themselves, that they're very impressive with the longest PFS and the highest response rate we've ever seen in this disease. If you look at overall survival, there's also an impressive signal here, a hazard ratio of 0.66, so very similar to the other trials. All the trials in kidney cancer that have shown a survival advantage, the hazard ratio has been 0.6 something, so it's been in the mid-0.6s. So one question is, gee, if the progression-free survival is so long and the response rate so high, why isn't there a more impressive survival signal in this trial? I don't know the answer to that, but most of the patients randomized to sunitinib would have gotten subsequent therapy and subsequent immune therapy, and this trial was conducted a bit later, so it may just be a bit of the effect of subsequent therapy, but I think the jury's still out on that a little bit. If you look at response rate data for this trial, as I mentioned, very impressive. Highest response rate we've seen at 71%, a CR rate of 16%. I warned you that CR isn't everything, but certainly a CR rate of 16% is pretty impressive. We don't yet have data on deep responders and other things I've talked about with other trials, and a median duration of over 2 years. So in line with the other IO-TKI regimens, but does look perhaps a notch better. Again, still waiting for some of the data to mature. And this slide just takes us back to the summary slide now that I've gone through a little bit of the detail of each. But again, high-level summary is impressive survival advantage for what we call IO-based doublets as frontline therapy, tumor shrinkage and control rates, certainly with the IO-TKI regimens and CR rates, and now we're getting to meaningful follow-up in the IO-TKI, but still have some work to do in terms of the durability of the IO-TKI response. But clearly a new era, and an IO combination therapy is the standard of care for patients when they come in the door, and I think really should be applied to anybody who can receive it unless they have an absolute contraindication based on these benefits. So just to go backwards a little bit, one of the questions that comes up is, gee, favorable risk patients do really well. They do well with a VEGF agent. Biologically, they tend to be more angiogenic in their phenotype and genotype. And so why don't we just give them a VEGF agent by itself, and then we can always salvage them with immune therapy. So this is debated in the field. This slide reflects my bias. These are data from Keynote 426. And if you look at the favorable risk subset, which is about 30% of patients, you see advantages. You see a 20% response rate advantage. You see a doubling of the CR rate. You see a 3-month advantage in progression-free survival. Notably, you do not see an overall survival benefit, although most of those patients are still alive, so you probably wouldn't see it. And there may never be a survival advantage in that subset. But in my opinion, the response rate and PFS advantages are enough to give dual therapy to those patients. And 2 important additional points. One is that you're really not adding much toxicity when you add an immune therapy to a VEGF agent. Most of the toxicity of these regimens is driven by the VEGF agent. And the other thing, which is in the bottom bullet point, is that VEGF monotherapy does not cure a single patient, in my opinion. We all have anecdotes of long-term response and this and that, but at the end of the day, it's really not curing patients. And if I walk in the door tomorrow with favorable risk disease, I want dual therapy. I want immune therapy because I want a chance at cure. And I think IO-TKI combinations provide that to favorable risk patients. Again, this is debated. Others have a different opinion, but it's something that's talked about in relation to these patients. So just some take-homes on the pros and cons. The other main issue is debating, gee, somebody walks in the door, do I give them an IO-TKI combination or do I give them an all-immune combination? This has been debated for a while, will probably continue to be debated, and we will never settle this question. But listed here are some of the pros and cons, and I've really already mentioned these, that IO-TKIs have pretty consistent effect across risk groups, high tumor burden reduction, pretty manageable toxicity we'll talk about in a second, and some quality of life maintained in data that I haven't talked about. But again, we don't quite know about durability. I think we'll get there in a year or so, but as of today, we don't quite know. And there's certainly potential for toxicity with continuing. We don't really know how long we need to continue each component here. The all-immune combination does have advantages over TKI monotherapy, but again, not PFS advantages over IO-TKI combinations. Durability is really the calling card of that regimen. And we have now 4+ year data to show durability, to show tail of the curve. So, my friends who are promoting that type of regimen will often point to that durability is important, and they're absolutely right, and that's the strongest data set. On the con side for an IO-IO combination, getting through ipi-nivo induction can be difficult for some patients, so there's more upfront inflammatory toxicity. You don't quite have the disease control that you do with the VEGF-containing regimens, and as I showed in those initial curves, there's less of an effect in favorable risk patients. That's not to say no effect, it's just less of an effect, and we don't know how to select for those patients. So hopefully a relatively balanced view of the pros and cons of each approach. So let's turn now and talk about safety of these regimens. I've alluded to it, but not really talked too much about it. And these recent advances are certainly exciting for patients, but obviously the other side of the benefit-risk equation is the risk or the safety considerations of these combinations approaches. And it's really about employing effective strategies to mitigate and manage adverse events or AEs related to the various components of these therapies that I've just shown you the great efficacy data for. So when we look at the spectrum of immune-related adverse events, or often called IRAEs, what I tell the patients is that these drugs take the brakes off the immune system, and they're meant to generate inflammation against cancer cells, just to put it in layman's terms. The side effects come from inflammation generated against normal cells. And as you see from the diagram, those normal cells can be anywhere, right? So you can have inflammation against the skin causing a rash, against the gut causing diarrhea, against endocrine organs like thyroid, against more serious organs like lung and heart, et cetera. So any organ can be affected. Thankfully, some of the more serious organs are much less in incidence. So myocarditis, for instance, I think it's 0.5% or some very low percentage, but it's almost uniformly fatal, as opposed to something like rash, which is the most common and generally not fatal. So again, I think now that we're 5+ years in, there's a pretty good understanding of the spectrum and awareness of this, not just among oncologists, but emergency room doctors, internal medicine doctors, other specialties that get involved here. But it's really about inflammation against normal organs that leads to immune-mediated toxicity. So again, sort of looking at our dual immunotherapy compared to an IO-TKI regimen, you see some of the same side effects are caused by both. Diarrhea would be common to both, et cetera. Fatigue would be common to both, but there are some unique ones as well. Quite obviously, dual immune therapy is going to give you more of those upfront inflammatory toxicities that I mentioned. But when patients get onto a nivolumab maintenance, it's often easier than being on an IO-TKI regimen. IO-TKIs are more chronic toxicities, more sort of longer term, if you will, toxicities that you see listed there, including some transaminitis, which is somewhat unique to the IO-TKI combinations. So a little bit of a different feel and also a different sort of timing of side effects. So this gets to timing. When do they occur? Well, with immune checkpoint therapy, and this is a broad statement, whatever regimen contains an immune checkpoint inhibitor, it can be very early. It can be after the first dose. I would say with Ipi/Nivo, it's commonly after the second or third induction dose is when you really start to see these immune-mediated toxicities. But they can be delayed, and there's certainly reports of patients who've stopped therapy and then experience an IRAE months after stopping, and sometimes quite significantly so. So again, I think there's general awareness that these occur, but the timing might not be as much of an awareness around the timing. So this is a classic graph. It's now published, gosh, almost 10 years ago, and these were melanoma patients. And it just kind of shows the different kinetics of onset. So as I mentioned, rash is often the first thing, a few weeks in, and then GI toxicities, diarrhea, colitis, and then some of the endocrine or liver toxicities tend to occur a little later. And you can see that the time course for these resolving is generally over weeks. Of course, many of these patients require steroids. The endocrine toxicities, thyroid, pituitary, which is listed, hypophysitis, those don't resolve on their own, and most of those patients will require replacement steroids or replacement thyroid hormone, whatever the case may be, for life. It's not that big of a deal to replace those hormones, but it's not something that gets better with steroids, and those organs don't start producing hormones again. So again, just a little different character and timing, but I think it does give you a good sense of when they occur, and not only the kinetics of onset, but the kinetics of resolution as well. So what are recommended strategies? There are many different guidelines for this. I would refer you to them. They're really, really well thought out by major groups across the world. Generally, for low-grade toxicity, you might hold, you might not, and just treat symptomatically, probably not give steroids for low-grade toxicity. As the grade increases, of course, then you're more likely to withhold therapy. You're more likely to prescribe steroids. There is no magical steroid dosing, and everybody does it probably a little differently based on their experience, based on how sick the patient looks, based on the organ that's involved, et cetera. Generally, though, early steroids when needed is a good strategy. Trying to rapidly taper, but also sometimes if you taper too rapidly, patients will go backwards and you'll have to go back up again. So there is an art to tapering quickly, but not too quickly. And again, it's sort of just an individual feel thing as you treat more of these patients and sort of understand the individual nuances of each patient. And then quite obviously, as we get into high-grade toxicity, that's when it's more serious. You require hospitalization sometimes. I would encourage you to get your specialists involved early, whether that's GI specialists, lung, cardiologists, et cetera, and really engaging them in the management of these patients, high-dose steroids, et cetera. And as I mentioned, ASCO, NCCN, SITC, ESMO, and probably others have really good IRE management guidelines. I have them on my computer desktop. We have them up in clinic. It just helps sort of know in the algorithm sort of how how much intensity of anti-inflammatories you need to give patients. And you see other steroid-sparing agents listed there, like infliximab or mycophenolate, et cetera. And as you get more into this, certainly I've used those, with good success in patients who need it. Steroids are almost always the first step, but I would have a low threshold to use other agents in patients who need it. So what about IO TKI? They present a unique sort of profile because of the distinct mechanisms of action. There are distinct toxicity profiles, but there are also common ones as well, such as you see listed rash, diarrhea, transaminitis, et cetera. One of the challenges of the IO TKI regimen is determining what's causing what, because you don't want to give steroids if it's from the TKI. You don't want to not give them if it's an immune-mediated toxicity, et cetera. And so generally TKIs, depending on which one it is, will have a shorter half-life than the checkpoint inhibitor. It's certainly true for axitinib with a half-life measured in a few hours, so that if you hold that drug, if it's related to the drug, it should start to get better within days, sometimes within one day. Whereas certainly an immune-mediated toxicity is not going to get better in a day without steroids. So the timing of resolution is a very good way to determine causality. It's not perfect, of course. And again, it often just depends on how sick the patient looks. But for these regimens, when I'm using them in clinical practice, I try to hold the TKI, see what happens, and then manage the patient based on that. Again, it's not always that simple, of course, but I would say for 8 or 9 out of 10 patients, that strategy works just fine. Multidisciplinary healthcare teams, as I alluded to, are really important. So I'm blessed. I have wonderful nurse practitioners and nurses and pharmacists in clinic with me, all of who know these drugs very well and know the AEs. And, we sort of jointly take care of patients. So having an engaged team who communicates well is really important. Having other non-oncology specialties engaged, as I mentioned, is really important in the management of patients or recognition of such toxicities when these patients show up in the emergency room. Educating patients on what to look for. And I tell them, I say, listen, we don't have cameras in your house. You have to tell us what's going on. You're not bothering us. That's our job. So tell us your toxicity. Most of it we can handle over the phone. But if they wait and call us when they're very sick, late on a Friday, we can't often help them and we have to send them to the emergency room, which is less than ideal. So again, it's just about empowering patients and often their loved ones to tell us about their toxicity and then having an engaged and educated team to manage those toxicities. So let's look at a patient case and talk through some of sort of the implications and consideration that these combination approaches bring to the clinic. So this is a patient of mine, and we'll sort of start on the left and move to the right along time. So this is, I guess now, over 6 years ago, this patient presented with a left-sided renal mass that you see pictured, classic clear cell kidney cancer that's hypervascular on the rim, more necrotic towards the center. Again, radiographically classic for clear cell kidney cancer. About 6 centimeters, normal renal function, normal labs, and did not have other disease. So of course that patient underwent an nephrectomy, standard of care for localized disease. The pathology was the most common type, which is clear cell kidney cancer, so-called because the cells look clear under the microscope. This patient also had some sarcomatoid changes. We haven't talked about histology, but sarcomatoid is an aggressive growth pattern that can occur in any histology. And the more sarcomatoid, the more aggressive it is. It's also more immunoresponsive. And I didn't go into that data, but subset data from the trials I presented, it seems that patients with sarcomatoid changes are particularly responsive to immune therapy, which is good because they're not often responsive to anything else. So it's sort of a fortunate coincidence that those patients tend to be immune responsive. Anyway, this patient way back when had localized disease, had his kidney cut out, and then of course was just followed with surveillance. A few years later, had some very small lung nodules detected that you see listed in right lower lobe and left lower lobe. Consistent with metastatic disease, but not definitive, too small to biopsy, good performance status in normal labs. And so we just kept observing this patient. There are data to support observing low volume indolent metastatic kidney cancer. I do it probably in 10% or so of my patients, depending on the age and fitness of the patient, depending on where the disease is, depending on the pace. It's also one of those feel things. There's no equation for it, but I do this quite often in clinical practice. And then, of course, you follow those patients, and as disease progresses, at some point they will need treatment. So as we move along the timeline to the right, you see the patient has progression of lung nodules, now developing, chunkier nodules, bigger tumor burden, Sometimes they have new organ involvement. They might have a lymph node, as this patient did. So at that point, the patient's moving towards needing systemic therapy, and I'm starting to discuss with them more seriously different regimens and when should we start, and conversations around toxicity, et cetera. So this is now, I guess, not quite 2 years ago. The patient started an IO-TKI regimen, had just had some mild anemia, which was the only IMDC risk factor. So this patient would be intermediate risk for the IMDC criteria. Did get a lung biopsy, which confirmed recurrent kidney cancer. No sarcomatoid elements seen in the biopsy, although again, remember, that's a fairly small piece of tissue. So it's hard to say whether his recurrent disease was sarcomatoid as well. It probably was, but the biopsy didn't prove it. So this patient began axitinib, 5 milligrams twice daily, and pembrolizumab. Presented for the third dose of pembrolizumab, was doing well, clinically well, no fatigue or diarrhea, but developed LFT abnormalities that you see listed there. So normal at baseline, and then about 3 or 4 times the upper limit of normal after the start of therapy. This is not uncommon with these regimens. It happens in about 20 or 25% of patients with this particular combination. The general strategy is to hold both drugs. If it's from the TKI, axitinib in this case, with its short half-life, it should start to get better in 3 days, and I'll usually check LFTs 3 days later. If it's immune-mediated, it's certainly not going to get better in 3 days without steroids. I generally try to avoid steroids in these patients. This was a lesson learned over treating many of these patients, many of whom don't need steroids, and most of whom will simply respond to just holding the TKI. And then if the LFTs start to come down and it's TKI mediated, then I'll go ahead and give the immune therapy. And then I'll generally restart the TKI, kind of depending on their other side effects and how bad it is. And that's sort of a feel sort of thing. But generally, once they get down to baseline or grade 1, I'll go ahead and restart the TKI. Quite obviously, watching that patient closely after the restart. Some may develop recurrent abnormalities and some may not. But that patient obviously needs a little more attention in terms of lab work and LFTs than would be typical.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/BZT860. This activity is supported by an educational grant from Pfizer.